Second case, 10-year-old female with a VP shunt, progressively decreasing level of consciousness, and you need to control the airway. You put an ETT in and you confirm that it's absolutely not in their esophagus. You hear good air entry bilaterally, but you're not getting great oxygen tracing. You're kind of like, oh, okay, you're in the high 80s. You're putting her on O2. The pressures are going up on your vent. You've got good CO2 back, but right now you're like, okay, this patient doesn't have lung disease. Why am I running into this oxygenation issue? So what's your question now?
The right depth.
Yeah, is the tube too far? I guess you could also say, does the patient now have a pneumothorax? So there's all the dope stuff. So there's a bunch of questions there, but probably your main question in the setting of a patient that is, previously oxygenating well is going to be, are they main stem as a result of you putting that in? So what techniques do we have available to us to check for main stem intubation? Probably the one that you'll see the most quoted in the literature is lung sliding. There's also a technique called tracheal dilatation, and then there's fluid cuff inflation, which is going to be the one that is probably we're, I don't know, the biggest proponents of, though I would say we use it a lot less often than perhaps we should because of the challenges in getting people to want to do it. But we'll talk about what that is. So lung sliding. Oh, main stem. So apparently I got auto-corrected there. So what do you guys see here?
You see nice lung sliding on the right. Mm-hmm. You don't see such a nice lung sliding.
Yeah, I agree. So this would be your classic lung sliding finding in the setting of someone who has a main stem intubation. Nice sliding on the right side, and then the left side is looking pretty dull, right? So, with this kind of appearance, your questions come down to, do I think they're main stem intubated or do I think they have a pneumothorax? And probably if they've just been intubated, your answer is a little bit more obvious. And then probably the thing you would want to do is to pull that tube back a little bit to start seeing that I'm now seeing lung sliding on that left side. So the challenges here, we'll talk about a pitfall. So here's your lungs, you got a nice tube in there and it's sitting in your right main stem. And so typically what that's going to mean is your air is going to be going to that right side, right? And you've got movement on the right side, as you can see, and you've got no movement on the left.
Greg, that's the slide of the year.
This is the slide of the year? Yes. Oh, it gets better. Now, what if I was to tell you that air goes where it's easy to go, right? So if you've got all this pressure on the right side, and now a little bit of it trickles on to the left side, you're going to result in what? Basically seeing the same thing on both sides, right? But you're still going to have a patient that's desatting. You're still going to have a left lung that's not fully inflated. But by ultrasound, you're going to basically see something that looks quite similarly. So lung sliding is not perfect. And when they've looked at some of the studies doing this, the sensitivity for picking up a main stem intubation is not as high as some of the other methods we will sort of talk about. And you can certainly be misled into thinking somebody has normal lung sliding by using this. It's not nearly as bad as checking auscultation, but it's certainly not as good as some of the other ones. As far as tracheal dilatation, I'll talk a little bit about that. It's not something I know a ton about or have done a lot of, to be honest with you, but the studies behind it seem to show some pretty good numbers. So tracheal dilatation is basically the idea that when you look at the esophagus and you inflate the cuff, the trachea expands a little bit, right? So you put a little bit of pressure on that trachea. Now, I think there's something around you wanting to expand it and then reduce it a little bit because you obviously don't want to keep your cuff very snug up against the trachea for a prolonged period of time. But the idea being that if you inflate that cuff, you'll see that trachea expand a little bit because of the cartilage there. One of the contentions with this one, at least in kids, is that because the cuff tends to be relatively large, that you can actually see dilatation quite a bit downstream from where the cuff is. And so you may not be very clear about where exactly that tube is sitting as a result of this. Because if your cuff is inflating your trachea, let's say 2 or 3 centimeters below where you actually want your cuff to be, that can certainly be still right mainstem, but you might actually see this finding in the place of where you're looking for the ultrasound, right? So you put your ultrasound at thoracic inlet, and you will see some dilatation, but that actually might just correspond to some downstream expansion of the trachea. So people who've done this before, and more than I have certainly, would contend that this is not as good as the next thing we'll talk about, at least in kids. However, in adults, this is well studied. And when they looked at a study looking at auscultation, which is the sort of classic anesthesia way, or, you know, in general clinical way of telling whether someone's mainstem intubated, the sensitivity and specificity of this technique, the tracheal dilatation, is 93% for sensitivity, 96% for specificity, with basically the same positive predictive value and negative predictive values. Whereas for auscultation, you're talking about a sensitivity of 66% and a specificity of 59%. So certainly much better than auscultation, which I think all of these techniques are certainly going to be if you look at them. But certainly this is one that, at least in the adult population, has been well studied and certainly seems to be very helpful.
The concept, like, if you see tracheal, like,
if you look at, yeah,
you inflate
the cuff, you should see that the width of the trachea expands.
As a supersternal notch, it means that you're in the right place. That's what you say?
Correct. Yeah, correct.
If you don't see,
because your cuff, if your cuff sits, the implicit thing that's behind that, which is also actually also implicit with the next one we'll talk about, is that if your cuff is at the suprasternal notch, that corresponds to something around like 2 centimeters above the carina, which is like your optimal position, right? So I should have said that at the beginning. But basically, you want your cuff to be where your ultrasound probe is. And if it is, that often corresponds to a good tube position. Not too high, not too low.
But they related to the fact that it can be like too high or too low, or only like in this.
So
if you don't see, you don't know, like, right? Like too high.
So in this one, they answered just trachea or mainstem. It did not answer whether it was too high
for them,
specifically.
If they haven't seen, it's a mainstem. Like,
sorry, what are you saying?
If they don't see tracheal dilatation, for them, like, it's a mainstem.
Correct.
That's what they do.
Correct. Yeah. So that would be their way of saying, is it, you know, because if it's in the mainstem, you presume that your dilatation is going to happen somewhere in the mainstem, and you're not going to see it up there. It's not clear how true that is in kids, whether you might still get some dilatation. And of course, in kids, you're talking about a much smaller area that you have to be precise within. So
joining the two things together, like no sliding the left with no tracheal dilatation, the chances are that the tube is probably low.
Sure, you can always combine. So combining techniques in any case is always a good idea, increasing your sensitivity and specificity, because obviously there are things that will fall between the cracks for each of those. But as a rule, it would seem that the lung sliding is less sensitive and specific than it's certainly less sensitive in the sense that you can have times where you will have lung sliding in the setting of right mainstem intubation. So probably if you're gonna, like, I mean, obviously you can only spend so much time looking around, but this is probably one that's a little bit more, at least better testing than the lung sliding issue.